Good morning, and thank you for your time today. My name is Michelle Halby, and today I'll be presenting my quality improvement project focused on a safety gap on my unit, which primarily deals with transplant care. This is the lack of a standardized workflow for post-operative patients who use GLP-1 receptor agonists or who have a history of a gastric bypass. These patients have a unique physiological risk that directly affect their care postoperatively, and our current workflow does not effectively mitigate these risks. Today, I'll walk you through the problems, the evidence, the interventions, and how we will evaluate the success. This is part of my quality improvement project from Nursing 405, Leadership and Management, Clinical Capstone under Professor Ray. So the moment everything changed. So let me start with how I see post-operative care. So a post-transplant patient, stable, recovering, doing everything right from the vital signs perspective. Suddenly, they stop progressing. Their stomach isn't emptying properly. We don't know that, but their medications aren't being therapeutic. Their nausea that they're continuously having, even when they're eating, maybe they're not eating a normal diet, is continuous. They're vomiting. This is considered normal post-op nausea on some perspective. And by the time we realize something more is going on, we're already far behind. So while these cases don't happen every week, it unfortunately is becoming more common with the increased use of GLP-1 and also a history of gastric bypass patients. Um, and it's not because they're sicker, it's just because of their physiology, it's just different. So GLP-1 receptor agonists and these bariatric surgery patients for gastric bypass, it fundamentally changes how their GI works. But yet our workflow hasn't changed with it. So that's what my project is trying to address as this gap. So what is the hidden risk in our unit? These patients have a decreased gastric emptying, which can cause a decreased immunosuppression variability. It also, the side effects, can have increased emesis because things aren't processing normally, and therefore increase the risk of an ileus. All these increase their pain and increase their hospital stay. And this is only because our screenings aren't consistent. Baseline bowel function isn't really documented appropriately. Early warning signs are missed. Bowel regimens aren't always started effectively, and they sometimes start too late. And this also can cause a variability in immune suppression, with the absorption being affected by the stomach, especially with gastric bypass. And for transplant patients, this unpredictability, it's not just inconvenient, it's dangerous for them. So why is this population different? It's two different paths, same risk. GLP-1 receptor agonists, they slow gastric motility as part of their mechanism of action, so they're designed to do. Bariatric surgery, they change the pH, the surface area, and the transit time permanently. Together, these risk factors increase the risk of aspiration, ileus, gastroparesis, dehydration, increased electrolyte disturbance, immunosuppressant variability. So a study of these transplant patients with prior bariatric surgery, they found higher rates of acute cellular rejection due to the altered absorption. This isn't a small thing. This is a predictable pattern. Something big. So what we aim to change, we want compliance, 60% compliance with a standardized protocol by December 1st, 2026 of this year. We want to identify the GLP-1 users and the bariatric patients clearly. We want documenting baseline bowel function so we know what to expect with these patients. We want to activate early bowel regimens, and we want to notify the APPs more effectively. So it's not about adding tasks, it's about adding clarity. So what success looks like for these patients. The outcome, we want to have a bowel movement within 48 hours or baseline by post-operative day 3, decreased risk of ileus, gastroparesis, and aspiration. We want a stable tacro or LSAT. We want shorter stay times in the hospital. So how do we do this? We do this with the process measures. We use screening completion. We use a GI flow sheet. Process measures, baseline bowel documentation, and the use of a GI flow sheet to document accurate I's and O's, and if they're actually having bowel movements, etc. If they're eating properly, it's the basic nursing 101 I&Os that I find aren't effectively done. So therefore, all this will lead up to put into place timely, effective notifications for our providers. So what we always need to balance this with diarrhea. We don't want our patients to have diarrhea. We don't want them to have open medications they don't need, and we don't want to increase the workflow. We do also want to prevent alert fatigue and documentation burden. And all these for improvement. It's not for unintended consequences and more work. It's to effectively treat our patients better. So what does the evidence tell us? Literature is clear. There are 3 risks. The first being physiological risk. GLP-1, they slows down gastric emptying, and bariatric surgery alters absorption. The ERAS alignment, which is the Enhanced Recovery After Surgery guidelines, they emphasize early oral intake, early immobilization, and structured bowel management, as well as workflow and electronic health record structure. Inconsistent documentation leads to misinformation. The EHR embedded tools are there for our benefit and the patients. We want to improve accuracy and safety. So what is the intervention? We're going to have screening questions added to the admission assessment to make sure we don't miss these patients. We need to make sure we have a documentation pathway in our EHR. If a patient screened positive, we're going to have prompts. Pharmacy will be involved with a pharmacy like so they're aware that these patients are more abnormal risk for delayed emptying and absorption. Provider notification should prompt, which should have an early bowel regimen activation if the patient is having nausea, vomiting, not able to eat a regular diet, not having the bowel movement. This will involve interdisciplinary communication between departments with a structured message template to ensure consistent communication and reduce compliance on just memory or just an overall just improper or incomplete documentations, because let's face it, we're all human. We're not always going to catch everything. What if we have a patient that's really high acuity and you're not able to catch these post-transplant patients that are like this? So it's just to make things easier for us and more consistent and safer for our patients. So how will we implement? This will be take a couple of months to actually do. This will involve a pilot. We have to refine it. We actually have to implement it, and then we actually have to continue it. Plan is for this to take about 9 months. It's a phased approach, allowing us to test, refine, and scale it to keep the staff engaged. This will involve education, the EHR build, a 4-week pilot, time to revise it and evaluate it, and then fully roll it out and continuously evaluate and adjust as needed. So cost versus value. So one prevented complication pays for this project. So this project isn't just clinically sound, it's financially responsible. Preventing one case of aspiration pneumonia costs $16,000 to $30,000. It'll actually pay for this entire project. Preventing a post-operative ileus costs up to $16,000 per case. This plan, as budgeted, should cost us around $11,696 according to data as of now. project isn't just about documentation, it's about anticipation. It's about recognizing harm before it becomes harm. It's about giving our patients, transplant patients, the safest possible start for their new organ and their new life. By standardizing how we screen, how we document and communicate, we're not adding just work, we're adding clarity, uh, we're adding safety, and we're adding consistency to the population, this population that severely needs it. So the future we're building for a safer recovery, clearer workflows, and better outcomes. I'd like to thank everybody for their time today. I know this is kind of a can be a very boring topic, uh, but it's also very needed, and it's like simple too, but it can make such a difference. These are my references.